Hey, welcome to Fire Engineers Hump Day Hangout to our show, Issues and Challenges in Today's Fire Service. I'm Chief Rick Lasky, along with my good buddy and Hump Day Hangout co-host, Louisville Assistant Chief Terry McGrath. And we've got a great show for you today with some incredible guests. I guess I can say we're excited. That word doesn't really go along with COVID, but we're excited because we talk here some people who are truly making a difference in the lives of a lot of people, not just firefighters, but we'll talk about that in a little bit. Now, normally, folks, we're on the third Wednesday, but we switched with our good friend Frank Ricci. So they had the third. We're here on the fourth, so we'll be back to the third next month. We'll be missing Chief John Salka and Chief Scott Thompson today with the switch. They ended up with a little schedule problem, and they're good. They'll be back with us next month. And as a reminder, if you have any questions, shoot over to Twitter and send them out our way. Please make sure you add hashtag FE Talk or throw them out there on Facebook, and we'll try to do our best to get to them. Today, our topic is helping first responders get back after the virus, the path and the steps needed for a healthy return. And let me just read off who our guests are going to be. We're going to have two more join us in a little bit, and then I'm going to turn this over to Terry. But obviously, we've got Chief Bobby Halton. We got the boss with us, and again, Bobby let us do the switching between the third and the fourth Wednesday with the other group. Bobby's he's the boss. He's our regular. He's our regular on this show, our regular cast. But today we've got Assistant Chief Homer Robertson with the Fort Worth Fire Department, our good buddy, my very good buddy. I absolutely love Homer. He's a great, great person, and he gets it. We've got Russell Burnham and Mike Connor from Frontline Mobile Health, and we'll get to that in a second. What the incredible programs that they're providing some folks out there. We're going to have Chief Jim Davis, the chief of the Fort Worth Fire Department, joining us, as well as Dr. Tim Harris. He's the chief medical officer at Texas Health Presbyterian Hospital, Denton, Texas. And he's going to, once he jumps on there, he's going to kind of walk us through what he's seeing come through the ERs and with all his docs and nurses and paramedics. But Terry, let's talk real quick before we turn things over. And I kind of hinted towards it's kind of funny to say exciting with COVID at the same time, but this program, I'm excited. I was excited when Homer told me what he was doing, what they were doing in Fort Worth with Russell and Mike's group. I know I called you right away. I know what we're going to do on the show. Well, I know what we're going to do because you and I Terry, have talked. You especially in Louisville, you've had so many guys out with it. I know what I went through, what my wife went through. It's like, and we mentioned this before we went live. It's like, okay, Bobby, so how you feel? Well, I think I got my taste back, and how are your lungs? Well, I still get a little winded. Well, okay, but you're released and you go back to work. And we do fit for duty tests. If you've been off for 30 days or better, or surgeries, but I don't know anyone, and we'll talk to the guys here in a second, that is doing this for their firefighters or police officers, city employees. I stole a little bit of Homer's thunder. This is so overdue. Like sometimes we move well in advance and we're pretty progressive. On the other hand, sometimes we're decades behind. So Terry, your thoughts before we turn it over to the guys, and I'll let you take the lead on this, but pretty incredible.
Yeah, so just quickly to lay the groundwork, and I'll tell you where Louisville Fire Department was. We've got 153 personnel in operations, and so we've come down with our fair share of positive COVID tests. I would estimate roughly 90% of those people test positive. They have a myriad of symptoms, whatever they are. They sit through the, in the very early stages of this, we had to get multiple tests, negative tests, those sort of things. But we would bring them back to work based on CDC guidelines. So they met the 14-day, then it was 10-day. But we basically would, we'd contact them and say, hey, it's January 2nd. You're eligible to come back to work. 90% of them walk back through the door, never heard another word. Well, we had, unfortunately for us, one of our guys that called us one day, about 24 hours ahead of when he was eligible to come back, and said, listen, I'm not ready. There's something wrong with me. I have a mental fog. I'm not thinking clearly. I can't walk down to my mailbox and back. And of course, we said, no, you come back to work when you can come back to work. You're not under a time crunch for us. But what it did raise was a question, and the question was, how do we know people are ready to come back? Because everyone has heard from A to Z what the symptoms are, what everyone's individual experiences are, and they're all over the map. So I do a lot of what I always do, which is when I don't have an answer, I start calling people. So I call Les Stevens in San Marcos. Les Stevens says, well, hold on. So he gets Chief Brandon Wade from Austin Fire on the line. I got Brett Stidham from Dallas Fire Rescue on the line. We had a brief conversation about how do we know what the path back to work is, and how do we know that someone isn't still suffering some effects of COVID when they report back to our stations. And I want to be clear, this isn't from a standpoint of infection control. I'm not concerned about that. And it's certainly not a punitive measure for firefighters, like I'm trying to keep them from coming back to work. This isn't punishment. What I want to make sure is, are we providing the right resources, and are we looking at the right data? I think the worst question in the world you could ever pose to a fireman or a cop or a military guy, these guests are former military, but the worst question you can ever say is, are you okay? Because we all know what the answer they're going to give us is. And that's what we were relying on. Anyway, through this brief conversation, everyone kept saying, hey, you need to call Chief Robertson in Fort Worth. They've got it going on over there. They are really on the cutting edge of looking at COVID, looking at what the complications of COVID are, and doing a adequate, correct assessment of their personnel, so that we know what we're dealing with, but really more importantly, so that the firefighter knows what they're dealing with. I reached out to Chief Robertson. He was real gracious to come on the line. We did a quick conference call with Denton County Chiefs, because what I had found out was most organizations are just like Louisville. We're going on the "Are you okay" method, and I don't think there's a worse method out there. So we had a quick conference call. They gave us some great information, and we are in the process now of implementing some of those assessments. And again, it's only impacting a few of our members. But I think as we learn from these few members, I think it's going to broaden what our interests and what our assessment needs to be. And I think Louisville will, what my goal is, and Chief McNeil's goal is, to get us to Fort Worth's place, whereas we're doing these full assessments on people. So anyway, that's what's brought us all here. And I hope that short explanation is already kind of raising some eyebrows, because I know, based on the conversations I've had, I think a lot of organizations, fire organizations, are sitting there shaking their head going, yeah, are you okay? That's where we're at. So with that being said, I wanted to also, Dr. Harris just joined us, and for our guests, Chief read his bio, and I listened to it closely. Chief Harris, he didn't short you at all, or yeah, Chief, I promoted you. Dr. Harris, he kept you straight and narrow there. But Chief Harris is working in the chief medical officer in the hospital community. So I was kind of interested in getting his take on what we're seeing. We all know what we're reading in the news. We all know what we're hearing from those who have had COVID. But I'm always interested to hear from the people that are in there, that are trying to move people around in a hospital and find space, and what we're seeing. And one of the things, I'd love to start off and shoot this right at Dr. Harris, but one of the questions, and I've heard this a lot from fire chiefs who are talking to healthcare people in the hospital setting, but any issues of people coming back 6 months post-COVID, and they're having maybe respiratory problems, or chest x-rays don't look good, all those sort of things. And I guess my question for you is there any information you can share with that? The validity of the reports we're hearing about chest x-rays and 6 month later complications that most people aren't experiencing, but I think you guys are certainly seeing?
Let me start first with explaining this COVID illness to you all. And I don't know how much you know or care to know, but this is a pretty unique virus in that it is similar to influenza. It primarily affects the respiratory system. The difficulty is that there's a cascading inflammatory response that does affect other organs, and where this virus attaches to within your system is a receptor, specific receptor called angiotensin converting enzyme 2. Angiotensin converting enzyme 2 is expressed primarily on respiratory epithelial cells, so the cells that line your respiratory tract, but it's also found in various levels, depending upon your genetic background, within your hearts, within your upper respiratory tract, lower respiratory tract, kidneys, and within specific immune cells, the T cells that fight off viruses within your system. And when you're looking at the spectrum of COVID diseases, you've got people who I'm sure you've all heard have asymptomatic disease. So people that have no symptoms whatsoever, or at least they have subclinical symptoms, they don't recognize it, to florid ICU care with acute respiratory failure, acute respiratory distress syndrome, and or death. So within that spectrum, it really depends upon your underlying genetic makeup and your underlying physiology as to whether or not you have advanced stage or comorbidities that would place you in those higher risk categories for more severe disease. Not dissimilar from influenza. I mean, I think you all do influenza runs within your paramedic units and your med units to a lot of nursing homes that have unfortunate outbreaks of influenza most every year. Coronavirus is no different from that, in that it'll primarily affect elderly or infirmed people. But there are some unique subgroups of adult individuals that get this disease that, based upon their genetic predisposition, may have more severe symptoms or prolonged symptoms. And some of those symptoms may be somewhat subclinical in that you don't necessarily appreciate them at first, primarily as a result of young adults' residual physiological capacity for normal work. So most of your guys are young and strong and fit. They all can wear respirators and carry 80 pounds of equipment on their back up 5 flights of stairs without thinking about it. So if I impair the average individual's lungs by 20 to 30%, it's probably not going to lead to much of a notice in their life or restriction in their life. They pretty much live bed to chair. But if I take away 20 to 30% of residual lung capacity in a young firefighter, you're going to have a substantive impairment in their physiological ability to perform their duties. And then on top of that, you have toxic environmental insults such as smoke inhalation or fume inhalation or extremes of temperature, and that can bring out subclinical symptoms that you wouldn't necessarily see this in other populations of people. And then you add to the dynamic that Chief McGrath talked about, where you've got these young guys full of bravado, and they're not ones to complain to you. And they also would feel that complaining not just would result in some degree of peer-to-peer pressure or a stigma, but also would potentially jeopardize their job performance, and that job means everything to them. So a lot of them are going to keep this quiet until it becomes such an impairment that it is overwhelming.
Well, and Dr. Harris, one of the points you brought up, and Terry brought it up, and we've mentioned it before, and we've had our very, very good friend, firefighter Andy Allison, on our show several times. And Andy's response, Terry, remember when he got electrocuted, normally he got out with the medics. First thing he says, I'm fine. And like, yeah, we know you're fine. You're still going to go to the hospital. Yeah, but I'm fine. And it's that normal thing of I'm fine. And they're not. And, it's one thing to talk about something that happens like that. This is something that firefighters, and thank God, and I wanted to mention before we went too far, Terry mentioned Mark McNeil, the chief in Louisville, who is an extremely progressive fire chief. And there's so many, like you look at, and Homer's going to be on her second, and his chief. Sadly, out of almost 40,000 fire departments in just the United States, let alone what we have with our families up in Canada, there aren't as many proactive fire chiefs, police chiefs, whatever, city leaders. A lot of it comes down to money and dollars, and they just want you back to work. And I can throw it out there. I can say it. I obviously would naming departments, but there are some that just they don't even consider long-term effects to their firefighters, doctor. And it just, especially with what we have to do, and even our law enforcement guys and those in the military, without progressive, forward-thinking leaders, you're going to see someone, and it's already happening. Let's advance 10 years and you're fighting with a workers' comp doctor because they don't believe what, you know what I'm saying? It's just, and that's why the program that Mike and Russell are doing with Homer and his Chiefs group is so important, because I don't think anybody else is doing it.
Well, the difficulty with this disease is that, you've got a young, vibrant workforce who probably will have either mild or asymptomatic disease. But even within that mild to asymptomatic cohort, we're seeing 30 to 50% of people with long-term residual issues that when you stress them physiologically or mentally, you're going to see some degree of impairment. The primary impairments, because that ACE receptor is on your lungs and heart, you're seeing people with progressive lung fibrosis. It's where your lungs turn from a nice soft kitchen sponge to a loofah sponge. You can't breathe. The scarring is permanent and irreversible and only treated with a lung transplant. And so if you take a young, vibrant guy who, has to do the physiological work that you guys go through, and you fibrose his lungs from this infection, it's irreversible damage. The cardiac impairment, 30% of athletes who develop COVID have long-term cardiomyopathies, which, you develop heart muscle damage where either the heart cannot pump as hard as it normally does, so you develop systolic heart failure, or you have arrhythmias and you drop over dead. And because you have this sense of invulnerability and the bravado that comes with the profession, unfortunately, this disease, even if you have mild symptoms, can have severe deleterious effects. And the other one, which is also somewhat worrisome, is the neurologic impairment. And that goes to judgment. And judgment is very important in your job. You do not want these people entering a structure fire with impairments, whether it's cardiac, pulmonary, or neurologic. If they can't pee, fine, that doesn't matter much. But you want their brains working, heart working, lung working, so they can do their job. And in people that are positive with this disease state, and currently you've got 50,000 infections in Denton County. Denton County has 890,000 people in it. So, roughly around 5% of the county is already positive. You've got 14,000 active infections. And you have a group of folks that unfortunately feel invulnerable and invincible. So these are the prototypical people that, although they're forced to wear masks on their job, tend to not wear them when they're in social situations. And you have a very highly social structure within your workforce. And so you guys not just hang out together when you guys are at the bunkhouse together, but you also, within the community, hang out together. And most of our spread within the hospital, we've only been able to document on 1,000 employees, 2 to 3 people that actually caught COVID here. Our PPE is effective. The mask wearing is effective for all of the COVID patients that we've treated, the hundreds of them. We have not had a documented patient to caretaker transmission. Where about 20% of our workforce has been affected is in their social lives.
Well,
and they put down their guard.
And I was going to ask you about that a little bit later too, when we get towards the end, is if you can think about, I'm going with this, is what recommendations we can give our, those riding the ambulances and the engines and stuff to help reduce that. But that's why I was saying, when I jumped on the phone with Terry and Bobby and said how excited we were to, Terry talked about bringing you on, Doctor, and then Russell and Mike with something that is going to help us put people back. And we've got some comments on it, right? We'll get to it in a little bit, but this isn't just, okay, you're over the flu, come back to work, like you said. It's much. My wife was bad off, and they told her she never smoked. She's never had a lung problem. She walks like crazy everywhere. And they said, well, this part of your lungs now, after, you had the double pneumonia and it's gone forever. But what we want to do is Homer, if you could, Chief Robertson, set up Russell and Mike and your relationship, what they're doing. We'll turn them loose, and then we'll kind of turn everybody loose, on that. But, how this all got started with Fort Worth. Fort Worth has always been cutting edge, always with anything they put their hands on. As a fire department, they're incredible. So if you could explain for the audience how you got this going with your relationship with Mike and Russell, and then how things are working there in Fort Worth.
Sure. Thanks, Rick. Thanks for having us on today, and Chief Halton, thanks for having us. So, we went for several months in the Fort Worth Fire Department without a positive case. I think we were like in May or June, even before we ever had a positive case.
How many stations?
We have about 950 people and 44.
Pretty good.
So we went months, and I think there was the doc brings up some important points. We had good procedures in place, we had good PPE in place, and we were not getting that patient contact of firefighters spreading COVID. We were bringing COVID from home, from our families, from people we met out on the street. That's where that was coming from. It wasn't coming necessarily from the job itself. We were doing a really good job of
Well, and Homer, real quick, I think that's an important point that I just want to jump in. I'm sorry, because Dr. Harris brought it up, and now you brought it up, and I'm sure Russell, Michael will talk about that. We're all hot to trot about what we're doing PPE wise when we're out on the ambulances and the engines, but we're seeing a lot of the exposures coming from away from that. It seems like a lot of people are in Fort Worth, for example, your guys, 40 something stations, you're doing what's right. It's like, guys, when we're away from here is when we got to be careful.
Right.
So I'm sorry, but I had to throw it in there.
That's fine. That's a great point. So currently we have somewhere around 280 or 290 positive cases. So we went from 0 in just a few months to about a third of the fire department have been infected. Now, one of the things that concerns us is that we know our guys and girls are tactical athletes, and we don't know what we don't know about COVID. We don't know what the long-term effects of that are going to be. Like the doc says, we get that fibrosis, and we take away 20-30% of our lung or heart capacity. And then down the road, what does that do as you age and you start naturally losing that, that capacity? So that really concerned us. Chief Davis was the one. So I'm very fortunate to have a very progressive fire chief that has an extensive medical background. I look for him to jump on here anytime. But
I was just going to say that when he was with his previous department, Columbus, he was highly regarded on the fire side, but especially on the EMS side.
Right. So he's recognized and is a noted lecturer and writes articles. And so he's super smart, was a flight nurse, but he was really concerned about that because he started seeing that in these COVID exposures in young athletes and the kind of issue that those young college athletes who ought to have been in super shape, the setbacks that they were encountering. He told me, he said, Homer, we got to do something to document that, because we don't know what the long-term effects are. And then we were already working with Russ and Mike at Frontline Health at Frontline Health doing our annual physicals. And they're doing a tremendous job there. And we reached out to them and said, we need a protocol. We need a post-COVID protocol. There may be some fire departments in the country doing that. I don't know of any right now. But so we're trying to bring folks in. I think we've done, we went to a city and used our CARES Act money to start with. And they said, well, if it's, you think it's important, that's great. But we also think it's important for police and other city employees. We've done about 180 people so far. We've still got a ways to go, and we're trying to figure out how to fund that. But that post-COVID physical, and I'm going to let Mike and Russ talk about that, is going to be a great. And some of those people have had they had a physical prior to that, so we know what they were like, and that we know what they look like now after they've had their COVID physical. So we didn't have everybody done, so we don't have everybody, but we're going to have some good data on that, and it's going to be critical for us as we go into the future. Just knowing what these folks look like after contracting COVID. So I'm going to let Russ and Mike jump in. Thank you for having, and I'll stay on the line here if there's any questions, and we'll let Mike and Russ jump in here.
Great. Russell and Mike, take it, buddy.
Sure, thanks. So like we were saying before the meeting started that, what we're doing at Fort Worth really wouldn't have been possible had we not had that commander medical officer relationship, which Mike and I learned in the military is so key, right? So the commander's understanding the fight out in the battle space and then saying, hey, look, like we've got to keep these guys on the line. So what do we need to do that? And so when Chief Davis and Homer approached us about saying, hey, like we have some serious concerns about firefighters returning after COVID, what are we going to do? So, we go to the books, right? We go to the sources. And so in the fire service, right? So you start with 1582, doesn't mention anything about COVID, right? Because it wasn't around during the last time it was written. You go to the IAFC and look at what's on their website and be like, hey, is there anything from the large organization stating what should be done? IAFF, nothing there either, right? So we say, okay, that's fine. So since there's nothing out there, where do we go next? So the next probably most authoritative source for returning to play, right? So if we call it returning to the fire ground, if we say, hey, we're not going to return to the field, the field's a little different for firefighters, but it's as close as we're going to get right now. And so the American College of Cardiology is something that Mike and I have really, they do care of the athletic heart conferences, and they're really good about sports cardiology. And we've kind of view our patient population as tactical athletes. And so they were probably way ahead of everybody else on, what are some baseline protocols for athletes returning to play, right? And what is a graded return to play? And so that's pretty much a proxy for what we've had to do at Fort Worth, is because it is probably the most reasonable approach. And so the post-COVID physical really is somewhat of a repeat for what they get from an annual. So all of the firefighters at Fort Worth and frontline firefighters, they get a cardiopulmonary exercise test. So if you talk to sports cardiologists, this is the same test that NFL combine guys are given. So when they go to the combine in Indianapolis, this is the test that the cardiologists are giving all the athletes to judge the cardiorespiratory system, to establish a baseline, establish the presence of any disease.
And Russ, real quick, I'm sorry, Homer had mentioned this because you guys have worked with them, and those that had the original physicals, you're actually able to. You've got the data now, right? Where you can look at start and finish now, if you will, where you're at, right?
Yeah, and I mean, sure, Dr. Harrison can attest to this, right? It's always helpful to know where you've been before you got sick, and now you're sick, to find out where are we getting? Are you even back to your baseline, right? Like in a perfect world, hey, if you can just get back to your baseline, I think that you can tell the commander, right, or the fire chief, hey, look, the risk, it's not that there's ever no risk, but there's an acceptable risk that if this firefighter's had COVID, they had symptoms and they've recovered. So what's our metrics for using they've recovered? So if their cardiopulmonary testing is the same or return to baseline, then we feel the risk is relatively low, and it's safe to sort of have a return to graded work for those firefighters. And so that's kind of the metric we use. Now, unfortunately, because this is our first year at Fort Worth, we have a lot of firefighters who've gotten COVID where we don't have that baseline data. But it just speaks to the importance of that for occupational athletes. Just ad hoc testing is not really the way to go. You've got to do it. And then to Dr. Harris's point, we don't know what the long-term effects are. So the only way you're going to know is to track that over time. And so, So really, to the inflammation of the heart and lungs, right? That's the biggest thing that we can kind of test for. The sort of neurologic symptoms that Dr. Harris was alluding to are really a little bit harder to tease out via laboratory tests or some sort of more maximal effort test. But that patient to patient interaction, and again, I hate to keep going back to be a broken record, but the military and the fire service, if the fire service is a paramilitary organization, this is kind of what Mike and I cut our teeth on. That's all that we really know how to do. So, we understand about, hey, there's, these guys wanted to do the job. And so they're going to lie to you as a medical provider as much as possible, because they're financially incentivized to go where they think they're emotionally incentivized or whatever. In the aviation world, which is where Mike and I got our occupational health experience, pilots, before the government and your taxpayer dollars give them the keys to a $33 million aircraft and say, go fly, they're saying, hey, look, we want to make sure that you are healthy, and that if we're going to invest all this time, money, equipment, training, educating you, arming you, that you're good to go. And then not only on top of that, we're going to do a deep dive at a reasonable interval throughout your career that gets more frequent as you age, because regardless of whether you're a firefighter, a pilot, or just a regular person, age is the greatest risk factor for almost all disease. So it needs to happen at a more frequent basis. And so, taking all of that, and I apologize to be rambling, but you
No,
sort
no.
of frame that in the operational mindset, right? So that what we're seeing and what Chief McGrath had kind of talked to us about last week is that, and we've seen this even before COVID with other things, is that you've got fire leaders in the fire service and fire chiefs that have firefighters that have been injured or sick, and either they want to come back and shouldn't, but again, because of what we've talked about, will lie or, bend the truth. And then they'll go to their primary care manager or someone that doesn't have that operational occupational experience. They're like, oh yeah, like you can go back to work, but that provider doesn't think like, oh, you program at Dell or you work at American Airlines. It's different being a firefighter. And so we've had phone calls from chiefs all over the state of Texas saying, hey, look, like I'm getting into a real sticky spot here. I'm getting medical providers telling me that they're good and the firefighters saying they're good, but I'm telling you, this guy can't walk down the hall at the fire hall without running out of breath. Like, I'm not buying it. Like, why can't anyone give me a straight answer?
I don't want to interrupt you, Russ, but I can't overemphasize how critical that point to me is. I can walk into my primary care physician, and if I have a sore throat, I'm looking to see if I got strep. No way in the world do I let that primary care physician say, hey, am I okay to go back to work? I don't say this disparagingly, and Dr. Harris is sitting here, but listen, if you don't understand what a firefighter does, it's not that simple. And that's where I think the fire service leadership needs to wrap their head around that and make sure that the proper assessment's done by the proper people. But firefighters need to understand that too, because ultimately it's their benefit. Sorry, Russ, but that is such a huge point in all of this.
No, it's really key. So
Hey,
again,
Russ?
you go ahead, Chief. Go ahead.
One thing I want you to touch on before you move on is what we're going to call I know we've all got a little COVID fatigue, but also the mental aspect of how COVID is affecting our firefighters.
So and we talked about this last week with Chief McGrath, is that for the firefighters that are having trouble recovering for whatever reason, right? Whether it's subjective or objective, they either they just feel they can't recovering, or there's actually, objective evidence that they're not recovering. The one thing that we're seeing after completing, so we've done 180 for the city of Fort Worth, and then we've also completed some for some other fire departments outside the Austin area, because again, this problem is not unique to Fort Worth, right? So it's not unique, and fire chiefs are needing help all over the place. But the one thing that we're seeing the most is that almost all our patients that come in have a level of anxiety that was not there previously. And, a lot of time it manifests as, hey, am I going to be okay? Hey, can I get back on the truck? And the question has never really been like, hey, you're like, to Chief Robertson's point, like, it's not like, hey, this is your job's on the line, and if you can't get back on the truck, we're going to take your job. That's never been the case and never been the messaging. It's always been, hey, we just want to make sure that you're good to go and that we're not rushing you back. In the Army, we always said, like, hey, we want to protect the soldier from the Army, but we also want to protect the Army from the soldier. It's the same thing in the fire service, right? So sometimes people want to come back too early, and if we let them back too early, you're actually hurting themselves. And there are sometimes, that the chief, maybe they're for operational reasons, or you're going to let that guy come back when he's really not ready, and you're just going to end up, causing some problems in the department.
And that happens. That happens. I'm sorry, Russ. All too often in my career, where guys have begged, they've actually went and begged doctors, I'm good, and they've done, and they to let them back. And we always talk about when someone comes back, the first thing the company officer, the lieutenant captain, is like, okay, Terry, are you good to go? Good. We'll tell you what, you're going to be inside with me today. I'm going to give Bobby the roof. Well, I am handling you, because I've seen guys come back after having minor back surgery and blow their back out and end their career. And I want to go real quick to Bobby Russell. Bobby, Chief Halton, and I have no problem saying this, I brag on Bobby all over the place, because when we talk about being proactive, he has spun things around. And I will say this in the fire service, where we finally have addressed the PTSD issue of things, where he's taught people that it's okay to not be okay, and it's okay to talk to people, where before you were a weakling and a coward, all the different stuff. And when it comes to the health and the both mental and physical of the firefighters, Bobby is a huge advocate of it. And I texted Bobby before saying, this is going to be a great show. 'Cause, I mean, between the doc and you guys in Fort Worth, it's just, this is going to be a great show. Bobby, I want to get real quick your thoughts on what we've been talking about so far.
Well, a couple of things jump out at me right away. First, Dr. Harris, thank you for opening it up with with some of the potential long-term issues that are going to be related to COVID, which I think we've long overlooked in some other disease process as well, and the pneumonias and some of the other things which our firefighters are prone to. So I think it's an area of concern for all firefighters. Obviously, we have presumptive laws out there for heart and lung and things like that, but most presumptive bills are very narrow in their scope and very I don't know. It's very hard to draw a line oftentimes between exposure and cancer because of the complexity of the human body and everything that goes along with it. COVID is in a different kind of class, if you will, and so is things that cause pneumonia and influenza and some other significant deals. Where COVID's a little bit different is the fact that it's a novel virus. And I think the doc laid that out really well. And then Russell and Mike kind of dovetailed with, really, there are no standards out there right now for what the care is, because it's kind of revealing itself to us as we go through this, and we're kind of at the beginning, really, of the entire process. To Doc's point about what the long term is going to be, more or less just the return to duty side of it, right? So it's a wickedly complex problem, and I don't mean to. I've been trying to stay as quiet as I can because I think what Fort Worth has done and Austin and some other places and the doc are doing are cutting edge, and really, what Mike and Russell have come up with make perfect sense to me. But again, like them, I was potty trained at gunpoint with a military model. So I understand, understanding the commander's intent is to have a healthy, secure, focused workforce. Now, in order to do that, the medical crew needs to make sure that we don't have any underlying conditions that are going to impede it. And obviously now with this new novel virus, we may be looking at things that we heretofore knew nothing about. Seneca kind of gave us absolution on that when he wrote, and I believe it was Letters from a Stoic, where he said that, our descendants are going to have things are going to be so plain to people a year from now that we just don't know, right? And obviously we'll allow the people in the media to throw stones at us for not knowing what they're going to learn a year from now that we don't know right now. And they're going to assume that we should have known it, but we don't know it. So I love what the doc is doing in terms of tracking, and I love what the organization is doing in terms of returning to duty. But I think beyond that, there's going to be this constant evaluation, right? So we don't know what this virus is going to do to people 5 years, 6 years, 7 years out. And then we have this other cohort of people that were currently introduced, who are the newly vaccinated people and who may get exposures. And how are they going to proceed through the system, right? And how is it going to affect people when they're they're in a self-contained breathing apparatus for an extended period of time? And then let's look at the hazmat people who may go longer. And what we learn here may be transferable to the people in the mining industry or the people in the chemical production industry, where people use the same kind of respiratory protection that we use. So, and then how are people going to be affected by the stressors that are unique to the fire service? In other words, intense heat coupled by intense physical exertion, coupled by intense emotional components, all of those chemicals at once in someone who's been affected, B, vaccinated. And that's my mother calling me, telling me to shut up. And she's been dead for 2 years. So miracles of modern science. So, so all of this is fantastic. One of the things I want to throw out there as a disclaimer of a caveat is that we are all learning more about this disease every day. So if your organization hasn't been doing this, please don't start throwing your bosses under the bus. We're showing you what is best practice right now in America. And thank you to Homer and Dr. Harris and Mike and Russ for being with us and sharing this. And so, one of the folks gave us a thing about contact tracing, which I think would obscure, and thank you, Rob on Twitter for sending that to us. Contact tracing is a big part of it when we start talking about presumptive. But for right now, Rob, I think what the discussion today is being focused on is how do we best evaluate our people returning from exposure? How do we best evaluate our people who've been inoculated and then may have minor exposure? And then, how do we capture that? And how do we turn that into, guidelines? We in the military, they're called desktop procedures, but we don't really have those in the fire service. But so desktop procedures so that men like Homer can keep, Fort Worth healthy, Rick in Wichita Falls, Terry down there in Louisville. And it may be transportable to a dozen different industries. So that's just my thoughts, on what I'm hearing so far.
Hey,
But
Hey, Chief, on that, go ahead, Chief. I'm sorry.
No, go ahead.
I was going to Chief Halton's point about, the long-term effects, SCBA. I wanted Mike to kind of jump in here because what the work that's Mike is doing is he's looking at what is, again, that operational overlay, not just like, can you return to work, but can you return to work as a firefighter? Can you return to operational suppression, right? What question are we trying to answer, right? So the answer we as clinicians are trying to answer with our evaluations is this person safe to return to operational suppression? And if not, that's okay. How do we get them better? Where do they need to go? What the intervals do we follow them up on? But really, so you look at that in that operational lens, right? So Mike is taking our data in those evaluations, and then, while we might not have evals on everybody, one thing we do have is we have 3 years of consumption data for every Fort Worth firefighter, right? So what is their bottle time, right? And so, it is, again, another proxy and an important one, a safety one. So, the longer that you can breathe on that bottle means the longer you can fight the fire, or the more time you have to get out, whichever it is, right? So again, it's a occupational, operational proxy for, hey, are you good enough to go back to work? How do we judge it? So I'd like Mike to kind of comment on where he's going with that, because I think that lends to the conversation.
Yeah, thanks, Russ. So one of the things that I did kind of initially was I went through a consumption test, a max effort consumption test with one of our partner fire departments, just to get an appreciation of putting on turnout gear, your SCBA, and then sucking a 45-minute bottle down and then just completely dying at the end, which was eye-opening because you get to see what happens on the fire ground in a very controlled environment too. And so that's another factor that's involved, is that's a controlled environment. You're not in a fire, you're not getting a flashover. But you are doing work. But when I got done, I got curious and I decided to take a look at I gave myself a cardiopulmonary exercise test out of curiosity to see how I was functioning prior to that. And I talked to our exercise physiologist on our staff, and we started to make links between certain parameters, like anaerobic threshold and power output, what the heart rate was at anaerobic threshold, and then marrying that up with bottle time. And it was a small sample value, but we could certainly see the correlation between the two from CPET and then consumption time. One of the things too that our exercise physiologist brought up is that when you put on your turnout gear and you've got your SCBA on, you've already gotten a 20% reduction in your VO2 max. So you're already impairing yourself. So whenever I do these return to work evaluations, and we've got baseline CPET data on these firefighters, these young men and women, who quite literally are mentally tough and able to kind of push hard in the paint and suck down that bottle as hard as they can. When you look at their baseline and you look some of their post-COVID stuff, you do see, especially if in the short-term post-COVID stuff, like within that first 60 days, you do see a little bit of a reduction in VO2 max. The things that kind of concern us the most is on the pulmonary portion of our CPAT testing, is you'll see some impaired CO2 exchange, which is indicative of inflammatory change at the lung tissue level. And in those cases, those are the times that we say, hey, like it's not time yet, right? Because these guys are mentally resilient enough, guys and gals are mentally resilient enough to keep pushing. And like Dr. Harris talked about earlier, is that young people have an incredible physiologic reserve. And he'll tell you that when that physiologic reserve runs out, it's out. It's completely out. You've got nothing left. You've pushed so hard and you've pushed them that you've got nothing left. And in operational fire suppression, that's a recipe for disaster. And so that's one of the reasons, when Chief Robertson brought this up to Russ and I, that we absolutely made some stuff happen, and those are the things that we're seeing. As far as the data stuff that Russ was talking about, I'm really interested in using CPET as a measurement, like a performance metric for predictive bottle time. And so it would be nice to see, like, if your anaerobic threshold is, in the upper 70s of your percent predicted max VO2, that equates to this amount of time or this range of time under a bottle, which, when you start off in the fire service, you can trend that stuff over time and you can see if there's things kind of moving on. And to kind of talk to Chief Halton's point, When you're doing these annual physicals and these long physicals that we'll do, we're capturing CPET data. So we can trend VO2 max, we can trend AT values over time. And then we already know who's had COVID because, there's a little box check under our patient history. And we can just track this stuff over time. And if we see gradual reductions that aren't consistent with age-based reductions that you typically see in VO2 max, then you can kind of make a correlation there.
Well, and Terry, you had something real quick, and I wanted to throw one of our questions out there, I think maybe to Dr. Harris, but T, I didn't want to cut you off. You had something, right?
Well, so what I'm fascinated about now, and I would assume that the scientists, the medical people on this call, is that, and why I think this is really pivotal. Like I think we're at a really, really crucial time right now, and that's to gather the data and let's get an understanding of what this is. I think it was mentioned earlier that unfortunately there's a large portion of this business that's very reactive, and that's problematic, I think, in this COVID world, because we're at a time right now where we have the ability to gather data. I think Dr. Harris could probably speak to that, is that, I've asked our medical director, what do we know now, 10 months into this, on the treatment side of things, how things have changed versus what we knew the first month when somebody showed up at an emergency room and what they were doing for people. And I roll that back into what we're doing in the fire service and everything that Mike and Russ have just spoken to, getting back to the other message about making sure you got the right people involved in this that are looking at the right things, because I think there is so much to learn in COVID in general, certainly a lot to learn just in the fire service.
Well, and I guess let me throw this one out there, T, as well, because one of the questions posed by one of our viewers, Corey, was, for the departments out there, they're using the 14, Dr. Harris, they're using the 14 days published by the CDC, and I'm not knocking the CDC. They're regardless of positive or negative test, they could have tested positive the day before. They said, yeah, but your 14 days is up. You have no symptoms, and so on and so forth. I mean, I guess if you had a room full of fire chiefs sitting there and they're asking you, so when do I bring people back? Or, and we would talk with Mike and Russell's program, but what would you say to them, Doc, if they're looking to you for advice, like, okay, when do I, because Terry talked about, I had guys that were going testing positive. They've been months with no symptoms, and then that whole, well, we don't need a negative test now kind of came into play. But what are your thoughts on, if the group of fire chiefs said, so Dr. Harris, what do I do? When do I bring people back?
Back to what? A desk job is one thing. Okay. But if I'm going to go enter a structure fire, that's a completely different issue. And I think it has to go to, you have to be totally keyed in to keeping your guys safe, period. So you have to look at what their roles and responsibilities are on the truck, and you have to look at what their condition was through that illness, and try to determine whether or not they should be on that truck. And the difficulty is, and I appreciate that you got an exercise physiologist in Fort Worth, but you got a lot of smaller stations, or Crum or Argyle, who don't necessarily have an exercise physiologist on staff, and they're going to go out to Podunk Family Doc out in Munster for advice, and that may not be, to Chief McGrath's point, that may not be the best person to assess that individual for return to duty. According to the guidelines, it is, if I develop symptoms of COVID, I return in 10 days. By that point in time, I've done shedding virus and I'm no longer infectious to other individuals. That doesn't mean that I'm ready to come back to work. If I have a severe disease, that means if I have more than 3 liters of oxygen requirement during my illness, then it's a 20-day delay in return to being around other people, to not being infectious. That doesn't mean you can come back to work. That means that you're no longer infectious. If you have a positive test, we know the latent period from onset of symptoms is 2 to 14 days in 99% of individuals. So at 14 days, if you have no symptoms, you can come back to work. So But it's either a symptom-based return to work status or it's a test date return to work status. That doesn't mean that they can jump on an engine, suck oxygen, and go into a structure fire. And then you're going to have to either, one, pay really close attention to that individual. You're going to have a sensitivity to your operations, and you need to watch them both cognitively and emotionally, because both are impacted by this disease. You have to make sure that they're not depressed, that they aren't fearful of their job. You need to have conversations with them because suicidality may increase, familial stress may increase, and then lastly, job security issues may increase. And then, are they physiologically capable of doing the job? Now, your people are a breed apart. I mean, most 20-year-old males and females have a metabolic, they're capable of driving at around 13.5 METs for males and 11.5 METs for females. And your guys are probably capable of 15 to 18 METs on some of your guys. And at what point in time is that metabolic consumption of oxygen at a point where you will not let that guy get on his bunker gear and enter a fire? Now, he might be okay to run support services. He might be okay to drive a truck. He might be okay to drive an ambulance, but he may not be okay to put on full bunk gear and enter a multi-story building to put out a structure fire. And the earlier comment about the physiological reserve, this guy is going to enter a structure fire. He's going to become metabolically compromised. He's going to have a lactic acidosis, and his physiological reserve is going to crap out when he's at a place where extraction may be difficult. And that's what you're going to be facing, is now you've got two emergencies, and one of which is a rescue of your own staff. Don't put your guys in harm's way by doing that. So I think the fire service needs to work with occupational health experts or exercise physiologists and really determine what type of physiological parameters do you need to re-enter active service, because otherwise you're putting in people in harm's way, and they, first of all, may not be aware of it. To my starting comment, you have no idea what your ACE2 inhibitor load is on your nasal pharynx or your lungs. You don't. They don't. They don't have any idea what their pulmonary reserves are after they were mildly sick. They have no idea until it's measured. And so some of you were giving me those squirrely looks on, yeah, thanks, Doc, for the big words. The point is that there's a lot we don't know about this disease, and particularly the guys that have the hubris of thinking that they're okay and wanting to be okay because they want to be back on the line. And my son-in-law, Andy Allison, wants nothing more than today to be a fireman again. Nothing more. But he will never, ever be a fireman again because of his injury. And there are people that will never be a fireman again because of this illness. And that's possible with just mild symptoms or even an asymptomatic physiological impact. They may not be able to enter a structure fire ever again if it damaged their lungs and heart in a subclinical fashion that can only be brought out by the excellent exercise physiologists that work with your departments. So you have a real brewing issue. You've got a 5% community impact of this disease right now. There's no stopping this. I mean, the vaccine won't be out mainstream until later on this year. Hopefully you all be vaccinated, but we're only seeing about 50% of our folks willing to take the vaccine in the hospital.
And again, I just did my second shot yesterday, and I know there's people that are hesitant for different reasons, and we can talk about that a little bit. But I know, and Terry had mentioned a couple times, and about let's have Russ and Mike walk us through, because just for our viewers, I just got one, and Chief Halton and Pete, our producer, are always awesome about letting us. Our hour is our hour. Don't worry about that. I had somebody say, please don't stop. They sent me a text message, and I'm like, we're not going to stop. This is way too important. The information that's going on.
That ain't the guy paying the bills there, Lasky.
But Bobby's always been good about letting us run over. But Russ and Mike, Terry was, we were talking about this before, about walking us through, one of your assessments, and then what are you looking for?
Hey,
Sure,
before-
I'll go ahead, Mike.
Hey, Russ, go ahead. You can hit that, but I did want to kind of talk about what Dr. Harris said earlier, is that we just don't know, right? That is something that I'm having to tell a lot of fire chiefs is we don't know what the long-term effects are, right? So I gave a briefing on COVID at a town hall, and I gave a briefing on the vaccine for one of our partner departments. And one of the things I talked about is the speed at which we identified the problem, and then how data has a long time to catch up to let us know what long-term prognosis is going to be like. We don't have definitive answers. We know that there's a pulmonary component, a cardiac component, and a neurological component. But what we don't know is like what's going to happen in 5 years, 10 years, 20 years.
Mike, real quick, I loved how you said data has a long time to catch up, because in today's world, like Doc was saying, that we're so used to instant stuff that,
That's
a lot of
exactly
people
right.
aren't patient enough, like you said, to allow the data to catch up. And that was just a great point you made.
It's the environment in which we live in, really, right? Like what people like, it took us 5 weeks to get the molecular, like the RNA sequenced. 5 weeks, which is amazing, that we positively extracted from an infected cell, isolated the RNA, and then, basically wrote it out. And then the vaccine came out some 6 months later. It was being produced and going through the process, less than a year later. But we still just don't know. We don't know what the long-term effects are. And that's part of science. Part of science is looking back retrospectively and then gathering that data from all these inpatient, hospitalizations, the outpatient treatments, and then saying, okay, look, this many people had this many people had this is positively linked to this. And you've got to take out all the noise, right? All the other comorbid disease, all the other genetic factors, all the other genetic components. And it's just going to take time. And that's the hardest thing I have to convey. But the only thing we can do in the meantime is look at previous data that Russ and I have collected on CPETs and compare it to serial data later on down the line and say, yes or no, this person has an impairment. But I'll let Russ talk about how the process works.
Yeah, and before I do that, I wanted to comment on Dr. Harris's point, and I think to Chief McGrath's point about, well, what does a chief do? How do I know if this person, hey, yeah, Dr. Smith at their PCM says that he's good to go, right? Go back to what, right? So this is so critical. And even if you don't do physicals or have an exercise physiologist, right? So it's kind of like thinking out of the box. I'll tell you how we do it in the military, right? So if a pilot who we have spent millions of your taxpayer dollars training and equipping and all of that stuff, they get a medical injury, whether it be from an illness, an injury, or whatever, and they have to come out of the cockpit for any length of time, usually about longer than 30 days. It's a whole new recertification process to get them back up to say, hey, look, you've been out of the cockpit too long. There's a graded return to play because the stakes are high. If you have a helicopter crash is catastrophic, right? Like that is not going to go well for anybody. Every time you hear about an Army helicopter crashing, almost never is there a survivor, right? So this is how we are. It's critical, right? And so we also look at how we apply our medicine is that, hey, look, like, yes, driving a Quint down an urban center is a dangerous occupation with other people's lives at line. And if you run that Quint into a building or another truck, it's catastrophic, right? Not just for your team, but the people that are there. And so to think outside the box. So for a graded return to play, even if you don't have the things that we have, to chiefs to say, okay, look, well, let's go back to the basics. Do you have any sort of functional test that you give in a controlled environment? So at Fort Worth, they have a maze, and in our partner counties down in Travis County, they do CPAT, right? They do CPAT, or they do a pack walk, or they do the IAFF fitness assessment, right? Like start somewhere in a controlled environment. And a lot of times battalion chiefs and training captains, those guys know, that when you see it, if that person's sucking it or not. You don't need our opinion to tell you that, right? Like maybe in the people that look really well, and we're looking at some real nuance about gas exchange in the lungs, and that person was probably relatively healthy, and it speaks to their reserve to why they probably look okay from a layman's perspective.
Russ, real quick, and you guys have seen this, everybody in this panel has seen it, where it doesn't matter. Depending on what they were actually doing, some guys are gassed, some guys aren't, some guys that are, on the bike all the time, whatever, what I'm saying? So if you don't have the baseline, the information like you guys were talking about, like the doctor was talking about, you guys, regardless of like you're saying, whether they're 20 or 40, if you don't have that information, consumption tests, something to compare it to, you're kind of like, well, I guess, he must have worked harder at this fire than he did the last one or something like that. Right. I mean,
Well, you can, but I mean, you can't pull the wool over somebody who's done it for a long time, right? Like if you fire, if you are a fire leader, meaning probably a company level officer or higher, and your guys, you see them every day. Before they got COVID, you would go to training with them and you see them around the fire hall. Like that intuition is still very important, right? So, we always encourage leaders say, you can make the call to be like, I really am not feeling that it's safe for you to be on the rig. And so, you know what, like, we're going to just let you go home, or, hey, can you just answer the phone? Like, everybody doesn't have to go home. Can we find you another way to be a active member of the team without putting you at risk? Right.
Two things to throw out here really quick, Russ, and Dr. Harris said it earlier. You're exactly right. You can fool the outsiders, but you can't fool the players. Right. So if you're on a team, whether it's military or the fire service, if you're not 100%, we all know it, and you don't have to be a rocket surgeon because it shows itself pretty quickly. To Dr. Harris's point, you can fool doctors pretty damn easily. I've been doing it for years, and no, seriously, I've made a career out of it. So that it's because exactly what to say. Doctors telegraph exactly what they want to hear. You're not feeling too bad today, are you? Nope, doc, I'm not feeling too bad today. You're not having any problem climbing 10 steps of stairs? No, sir, I'm not having any problem climbing 10 steps of stairs. It's because they've got to ask the questions in a format which is dictated to them by tons of research and standards, et cetera, et cetera. And firefighters, we've figured that out. So where it does get dicey, I didn't want to have to say it. I muted myself before I said it because I was thinking about, this is a tough thing to say. We only have so many light duty positions, Russ, just being honest with you.
I know. Yeah. Now we get it.
Now, if you work in a really great municipality that's willing to bend and do stuff for you so that you keep people employed, God bless you. And we may need to be looking at that. But the fire service in many organizations, and I've been a member of two, you had to be a full duty firefighter, period, irrespective of where you worked. So I worked in two organizations that had 0 permanent light duty positions. So that's a reality. So I don't want to, and I know we're live on a couple of different platforms. I don't want to give anybody any false hope that they, that they might be able to, do that. And I'm not saying that there aren't places where that'll be possible, but we've got to be really, I'm just trying to be as authentic as I possibly can be as a boss, right? There becomes a point.
But Chief, I think we owe you as the medical community, right? Whether there's light duty or not. I mean, I should not be using my clinical judgment to be like, well, I really know they don't have light duty and this guy really needs a job. So you know what, I'm going to say he's okay. Like that's not okay, right? That's not okay. Like if they're not clinically okay, regardless, you need medical providers.
And you're right. I need that. I need that honesty from you. I need doctors like Dr. Harris to be straight, because here's the downside. I can maybe fool a doctor. I can't fool you. If I'm not straight with you and you're not straight with me, somebody can get themselves killed.
You got to be really careful with informal accommodations. And I think we tend to make do with those at times, but those informal then become formal the longer you permit them to occur. It's a very dangerous place to live. It's
like a temporary tax.
Yeah.
Jumbo shrimp. They don't exist. You're either a shrimp or it's a tax. And light duty is really designed for the eventual return to full duty. If we know without equivocation, as the doctor said of his, I believe you said it was your son or your nephew?
Yeah, my son-in-law.
Your son-in-law. He's not coming back, period. That's tough news. And to be honest with you guys, my typical, you see me over here, I'm on page 16 of notes from you characters. I hadn't thought about that before.
Hey, while we have the frontline guys here, because really what we're hoping for, and all of you make great points, what we're hoping for is an opportunity to figure out someone who's compromised and then help them get back to filling a seat on a truck. So Russ, can you talk kind of briefly, just walk us through the process? What tests are you doing? And what is it? So a firefighter in Virginia or North Dakota can listen to this and has some talking points when they sit down with their providers or somebody that they want to maybe try to get an assessment on.
Sure, absolutely. So to Dr. Harris's point, right, and why his intro was beautiful, as he talked about, what are you trying to find out, right? Is there inflammation in the lungs? Is there inflammation in the heart, right? And then you have to have that face-to-face interaction to find out if there's some sort of neuropsychological issue component going on. So it starts off with lab work, obviously, right? You need to get the biomarkers. We're looking at a CBC. You're looking for lingering signs of inflammation or a leukocytosis. One thing that we're sort of anecdotally seeing is that people that had normal platelets during their annual physical are now having elevated platelets, which is just, again, we're crunching the data and looking at it, but I keep seeing that. I mean, there is the increased risk for pulmonary embolus or thrombus. And so it's kind of speaking to that. I have yet to have somebody explain that biophysiologic process as to why that's happening, but we're seeing that. We also look at markers of inflammation, right? So there's good ones, but aren't very specific. So a CRP and an ESR, again, they tell us that there's inflammation going on. It doesn't really tell us where. But if you're looking at a return to work, I'm looking for the absence of inflammation. So a 0 tells us a lot more than a positive. But again, if the chief's asking, hey, is this guy good to go back? We're saying, okay, look, we're looking for the presence of any lingering inflammation. So we do an ESR or CRP, and then we also do a troponin. So troponin is very specific, right? So we're looking for cardiac injury. Is there some myocardial injury still going on? If a firefighter had any sort of lingering troponin when we see them for evaluation, that's obviously, no, you are not ready to go back to any, just please continue to rest, follow up with your cardiologist. This is not, you're not there yet. And then what we're also doing is we're also doing COVID antibody testing. So, the tests, the one that we use is from Roche. That's the company that did it. And so it's not a specific looking at an IgM, IgA, or IgG. It's looking at a total antibody because the sensitivity and specificity for those individual antibody tests were kind of garbage. They just weren't good enough to go off of. So Roche has a pretty good test that looks at the total antibody count. What's also interesting is that some people think they had COVID. They thought they had COVID. They had a positive PCR nasal swab. And then when we see them for their eval, they got no antibodies. So it either means that they're a non-responder, which is sad, or it means that PCR was negative and they just had another virus. So that's helpful too. That's been probably one of the more interesting conversations with our patients is, hey, do I have antibodies? But the problem with that is, well, again, if we were talking about measles, I could tell you what antibody titer is acceptable to go back out without a booster. I don't know that with COVID, right? So, unfortunately, the test that we do for antibodies, we get into the vaccine now, and lots of our clients have gotten back the vaccine, is that the antibody test that we've been running does not check for the same antibody that's produced by the vaccine. So there's not a corollary there. And so people are like, oh, is my antibody test going to go up because I'm getting the vaccine? And unfortunately, the science, the testing isn't available at our level yet to do that. And then we look at some imaging, of course, right? Again, going after Dr. Harris's point, inflammation, pathology of the heart and lungs. So we do a chest x-ray, again, more limited, but it's probably more confirmatory. Hey, we don't see, some pulmonary inflammation. We don't see fluid in the lungs. We see a normal cardiac silhouette. We don't see a mass or something like that. Something that looks similar to pneumonia. That would be a good sign to say, hey, look, okay, your chest x-ray was not positive for anything suspicious. So again, a negative is a little bit more helpful than a positive because it could be a million different things. And then we do an ultrasound. So it's a pericardial view of the heart. So you're really looking for inflammation in between the heart and the pericardial sac. So it's called a pericardial effusion. And we've seen those more than I would have thought we would have seen. And so that's common. And again, that goes into risk stratification. Sometimes there is physiologic fluid around the heart. And so what is non-physiologic fluid around the heart? And you have to kind of judge that against all the other testing that we're doing. And then I really think the quintessential test is a more functional test, which is a cardiopulmonary exercise test. So like I said, this is the same test that they do at the NFL Combine. If you talk to sports cardiologists, they'll tell you a Bruce treadmill is not right for tactical or occupational athletes. That's the wrong test. So if you're getting on a treadmill without being a maximal effort and your gas exchange is not being measured, that's a poor test for a tactical athlete. So what we refer to as a stress test is not the right test for firefighters, and sports cardiologists will tell you that. So you really need to take in a controlled environment. So if the question is, hey, does this person have any lingering inflammation, heart injury? Are they good to go back to operational suppression? And that means I have to wear a mask, and I'm very well should expect to go to full maximal exertion fighting that fire. Am I good to go? So it's but it's done in a controlled environment. It's done with a mask, which makes it a little harder to breathe, but you're doing that breath by breath gas analysis, which is so key. And then you say, give it to me all. Give me your best effort here, right? This is a safe place to try to kick the tires. And we let them go. We say, hey, give us your all. And we can really tell, is their effort valid? Was their effort the same as previous? What was their pulmonary function? And CPET is probably more complicated to explain on this, and it's not as ubiquitous as it probably should be in the occupational health world, especially for firefighting. But it's also a full pulmonary function test. So you're looking at their lung capacity. Is that reduced from last time? And then you look at, of course, EKG tracing. So are they going into some sort of crazy arrhythmia the longer they get into exercise? Are they able to recover well? Like, we actually look at what the recovery is. Is their recovery impaired from what it was before? You could get into the questions about, when a firefighter comes out and goes into, the word is escaping me. But when they go and take a break and rehydrate and can't go in until their vital signs are rechecked, that really gets into that. Is like, hey, how many times can they go into a fire before they're going to need a longer recovery? So that's what the test encapsulates, plus a pretty detailed COVID questionnaire. So a prehistory, what were your comorbid conditions? How did you get infected? Do they think, again, how were you tested? What other medications are you taking? Those sorts of things. Were you hospitalized? Were you not? What treatment are you on now? What treatment did you receive for COVID? And again, we just tried to, this was, I don't know, Homer could tell us this probably about, 4 months ago, when we were just like, hey, we got to do something. So let's start going. We probably could ask some more sophisticated questions now than we did back then, but we just kind of threw a wide, shotgun group and said, hey, we want to try to ask as many questions as we can, because there's going to be important for the data, to Mike's point, to look back later on. So that's really where we're at right now is, so the labs, the chest x-ray, the view of the ultrasound of the heart, cardiopulmonary exercise test, and then just the detailed physical exam and a history, right? Like, you have to, they know if you're lying. As a medical provider working with firefighters and soldiers for our whole careers, is that one, firefighters know if you're lying, and they know if you care. And so that's why that physical exam and interview is really important, because a lot of times the anxiety is real. The anxiety people are experiencing is real. So that might not manifest clinically, but they feel it in, hey, I just can't catch my breath. Well, hey, that's cool. And I believe you and I can see it, but your pulmonary function is just as good as it was when we did your baseline testing 6 months ago. Your CPET's actually better. You had no inflammatory markers. And so that's very reassuring sometimes, where they just feel like, okay, well, I just need to know that, like, I'm okay, right? I needed somebody that knew what I do as a job and cared about me to tell me that I don't have cancer. It's always a thing for their annual physical. I don't have cancer. I'm not going to die. That's what they all want to know. And that's a great question for them to ask, but you can't just treat them like a number, right? You can't just be, hey man, you're good. You go back to work, go back to whatever work you do. They know it's just disingenuous, and they have a hard time with that. So a lot of frustration with that Chief McGrath has kind of shared with me and Mike is, a lot of guys getting just kind of run through the doctor's office and being like, you're good, don't come back. Like, you just leave. And he's like, well, I don't feel well. Like, why don't I feel well? I felt fine before COVID and I don't now. Is that anxiety? Is that some sort of lingering, inflammation? We don't know, but they're really not even checking either. So, so that's kind of broad strokes. I'm open to any other comments, or having Dr. Harris or Mike jump in there as well.
Yeah, and I would say your standard physician is not going to do that type of physiological evaluation, nor has the equipment to do that type of stuff. I mean, we'll send people through a standard treadmill test, which is more for cardiac disease than it actually is for physiological reserve when you're looking at occupational duties. So I would not, and no disparagements on primary care docs. I mean, I was one for 20 years, but they're just not looking at the same things that you guys are from high performance level folks. And that's the difference. Most of the population sits at a desk, and they're not exposed to what you guys are. So send it to an expert, and especially for those people that have smaller departments, maybe collaborating and trying to find resources within your areas to get this testing done on people that are COVID survivors, whether symptomatic or not. And I can't emphasize that enough, because those people that have subclinical disease may still have substantial physiological impairments that on peak physiological stress, when you're entering structures with bunker gear on, that is going to show itself at a bad time.
Okay, and real quick, Doc, someone posed a question, Russell. I don't know if you can jump on it real quick if you saw the question that was posted to the right. I have had a cardiac MRI that showed 2 spots of swelling in the heart, angiogram this past Monday with all clear, no blockage. What was the test again that Mr. Burnham was talking about to bring up to my cardiologist?
Yeah, I think Mike just reposted there, but it stands for cardiopulmonary exercise test.
CPAT,
And so,
not to be confused with CPAT.
correct, very clear, right? And so another great resource that's open source is the American College of Cardiology's COVID-19 Hub, right? So when you're looking at, and they do a great job of it. Again, they look at the athlete, right? Before COVID, they were already doing a lot of stuff in regards to athletes, and they're really leading the charge even before COVID. But if they want to go and educate themselves, and we always encourage our patients, hey, look, like try to go, Google's great for finding out what the movie times are, and sometimes for something small, but like go to these institutes, go to the American College of Cardiology, read their websites, even if you have questions, bring them to your doctor, ask those questions. When you see a cardiologist, you'll be able to ask those, like, why aren't we doing this test? I'm not advocating, we're not armchair quarterbacking therapy or testing for anybody, but you're about arming your patient with the questions to address their concerns. And then hopefully when they speak to that specialist can speak to that concern and be like, hey, yeah, this is important, or, you really don't need to worry about it, but this is why you don't need to worry about it. And I think that that's what's lacking a lot of times.
And that's great.
I think,
Great advice.
sorry.
Hey, Rick, and I know that we've gone pretty long today. One of the things that I'd recommend too for you and Bobby is to maybe look at having Russ and Mike come back on sometime just to talk about, I think Frontline is doing I know they're doing a tremendous job for the Fort Worth Fire Department, and in what we're doing in hiring, doing pre-hire physicals, and in just our annual physical process. There is some fascinating information coming out of that. And I think it would be very informative to the fire engineering Hump Day hangout groups to just listen about the work that they're doing for us there, and the impact that hiring somebody that maybe is in pretty good physical condition, but may not be able to make it as a firefighter for 20 or 25 years.
No, I think it's a great idea. And I know
So
Bobby's already nodded. Well, Bobby will be good with that.
I just want to bring up a couple things here is I think that whenever patients go to, so, not everybody has a front line. We wish everybody had a front line. But I think the important thing to try to do here is to get some sort of shared understanding with your PCM if you're going back to your primary care manager, and just explain the components of your job and what you do, because I don't know that they necessarily have an appreciation for the firefighting tasks, right? The 14 essential firefighting tasks that 1582 talks about. They don't have an appreciation for the physiologic changes that occur whenever you go into a structure fire, right? And just arming them with that information can kind of, and then bringing up the things that you want to get tested can help kind of drive your treatment and drive some of the testing that you want to get done. And I think that's probably the most appropriate thing that you can do without being without walking away and feeling kind of dejected from the process. I think that there's a lot of frustration, and the medical system is a little bit different now and a little bit more difficult now with regards to kind of getting some of these things done with some of these tests that you should be getting done whenever you're trying to come back to work as a tactical athlete. So just coming armed with information and having that shared conversation with your primary care manager will go a long way, so that they get a better understanding of the components of your job and what you really need to be ruled out for.
That's a great point. And I have to ask this before we kind of wrap things up here. And I think I'm going to point this one to Dr. Harris. And I think the first part of this is going to be easy for you. The second one, I'll let you decide. But I've gotten about 10 messages, and they've been, is there anything else, selfishly, is there anything else we can do as firefighters that we're not already doing that would protect us with everything going on? And the second one is, and this is a biggie, and I don't know, Dr. Harris, where you want to go with this one, but the part two of that is the vaccine is, everybody's, is it safe? Is it not safe? I'm waiting for the second round, all those questions that are out there. The first one is there anything else we can do to protect our people or protect ourselves better? And then the second would be, what do your thoughts to some of those that are iffy about the vaccination?
Wear a mask, wash your hands, keep 6 feet apart. I mean, that's really that, and limit your social exposures to people. It seems common sense, but I think that everybody's getting COVID fatigue. We're coming up on a year very soon here when all this went to pot, and I think people are trying to do their best in a bad situation, but we're certainly seeing community spread. The new super spreader variant that's currently in UK, it's now spread to the United States. We're expecting that to start hitting Texas area in probably late March timeframe, probably right after spring break. We're starting to see an uptick in COVID in schools, and kids are notoriously bad at personal hygiene and social distancing. As far as there was an earlier comment, are women and men disproportionately affected? Not necessarily by the disease state, but women tend to be a little bit more hygienic than men are, and probably a little bit more attentive to mask wearing. So, but the real key to this is the mask wearing. And then vaccine. For all that we know, the vaccine is about 95% effective, but that means that 1 in 20 people will not seroconvert to the shot or have an adequate immune response. And really, where it plays a role is a reduction in severe disease. That was the data endpoint that we really looked at. And people may still catch COVID, but have a less intense disease, similar to the flu shot. We need about 50 to 70% of folks in our communities to get the shot in order to get herd immunity until that point in time, which will not be in time for the super spreader virus to be in our communities. Unfortunately, we will not probably get rid of this disease. And there is a big question in the science community as to whether or not this will be a seasonal variant similar to influenza down the road, and we don't know yet. As far as the vaccine side effects, it tends to be a news media event when it occurs, and that tells me it's relatively rare. When they're handing out hundreds of thousands of shots and the only thing they can come up with is some doctor in Alaska had an adverse reaction to it, I would say that it's probably a rare event. We've given out close to 20,000 immunizations at Texas Health and have only had 3 events. As to whether or not they were truly allergic events or they were a physiological response or an emotional response to getting the shot, I can't tell you. I mean, I don't know enough details about those, but certainly some of the reactions are truly physiological allergies to the vaccine. The second shot does leave you a little bit achy or flu-like, similar to a standard flu shot, but it's nothing horrible. And, overall, we're hoping that it's effective, but it is the only pathway to normalcy. So other than that, we will be wearing masks. When you look at the epi curve in the community, we're in a relative flat plateau phase, and we're not receding yet. And it's been over 60 days for our recent plateau and recent surge. And, when you look at this compared to an annual flu season, it's a season for the flu. This has been an unrelenting year. And this is not normal for any of us to face. It's not a normal disease. It's only been around for a year. We don't know much about the long-term effects. The vaccine was just created in a very safe manner, in a very rapid manner. And that mRNA technology that's being used for both the Moderna and the Pfizer vaccine are very clean, very safe, very precisely targeting this particular virus. They carry no risk of DNA damage, no risk to your body. It doesn't. I mean, there's a lot of junk out there on the internet on this thing, and frankly, most of it is garbage. I had my shot already, and I'm thankful I did. And there was a line of doctors out the door who were getting theirs as well. So I encourage everybody to take their vaccine. Again, that is the only pathway to normalcy.
Well, and again, as we finish up here, I just thank God we have people that doctor, that what you're doing, what Russ and Mike are doing. We mentioned some chiefs. I mean, the chief right here in Wichita Falls, Ken Perlman, is a very proactive boss, and he's taken steps to do some great things. And I guess one of the messages, I would send to people is if it's the whole, if you see something, say something. If you don't feel good, if there's something going on, don't hide it. Don't, get yourself taken care of, and think long range. Doc, and I know you don't know this, but I absolutely adore Andy, your son-in-law. We've had him on this show a couple of times. Bobby's had him out to FDIC to teach. Andy Allison is just a class act. He's a great, great, great young man, and I absolutely love him. But I know Terry's got to go to retire center. Bobby's got to go for an appointment. Homer, my good buddy Homer, thank you so much for just telling me the other day. It was just a chance thing. He was like, let me tell you what we're doing in Fort Worth. And he talked about, Russ and Mike and what they're doing. And like I said, I ran to the phone and got with Bobby and Terry. And then Terry's right, well, we have to have Dr. Harris on. And guys, I can't thank you enough, with the information that you covered. I know Bobby said, Terry's been texting me going, capital letters, this is great. This is incredible. People need to hear what you guys, there's a lot of bosses out there that need to hear what all three of you, and including Homer, have had to say today, and that there is a voice, there is a method, there is information. There are people doing great things to get their people back to work and to take care of their employees. And if you're not sure about stuff, it doesn't make you a bad boss. You just didn't read the right thing, weren't exposed to the right thing. So here you are. So hour and a half that we gave you some great information. We always do this. I know Bobby, if they need your email, they just have to open up the magazine, and look inside. Terry, your T. McGrath at citylouisville.com. Homer, your email?
It's homer.robertson at fortworthtexas.gov, and Fort Worth and Texas are spelt out.
Okay. And please just thank Chief Davis for letting us borrow you and for everything he's doing. Russ and Mike, website for you guys, and what's the best way for them to get a hold of you guys?
Yeah, absolutely. So it's just pretty long but simple, frontlinemobilehealth.com. That's the website. We're on all the platforms, Facebook, Instagram, Twitter. Just you can get a hold of us there. And then again, we always tell our patients, if you're in the fire service, don't call us, call Homer, ask him his opinion, because you need to get it from another fire chief as to what's really going on. They know what's going on. We're just doing our best we can to help him.
Well, and that's perfect, because like I said, that this whole thing was spurred by just a great conversation with Homer. So for our viewers out there you go. Dr. Harris, Bobby, love you, buddy.
One quick thing, Rick. I do want to say thank you to the doc and everyone who's here. I really appreciate it on behalf of fire engineering and everything we do. To you two guys, how about you stand a little closer to the blade next time you shave? Doc, you're exempted, but you two characters, I still outrank both of you. So let's clean that up. Just kidding. I had to go there. These guys know exactly where I'm coming from. But thank you for what you're doing. I'll tell you what, I'd be proud to be with this crew anywhere. And Homer and I, and Ricky and Terry as old fire bosses, man, I'll tell you, rarely do I get to listen to the three gentlemen that are as focused and honest as you all were today. So I greatly appreciate that. And if there's anything that we can do for you going forward, we'd love to be available to you. Articles, podcasts, webinars, whatever we can do to help you get the message out there. And it also helps me. My kids need shoes, so they're just. But no, seriously, this was an amazing day, and I'm extremely grateful. So thank you all.
Thank you, Bobby. Dr. Harris, any contact info if we got a city manager or a chief or a mayor that wanted to talk to you, or the hospital website, or?
You can email me at timothyharris@texashealth.org. I'm happy to help out. And please, one selfish plug, love on your injured first responders and keep them in your hearts and your prayers. And I know that it means a lot to injured first responders to have active fire folks and people in that community reach out to them. It means the world to them. And I just thank you for all that you do for us to keep us safe.
Well, hugs to Andy. I know Terry talks to him a lot, but I love him. So guys, Terry, any closing thoughts real quick, buddy?
No, my apologies. I've got to run, but I can't thank you guys enough. And honestly, since I've been doing this with Chief Lasky, this is probably the most informative show that I mean, I'm taking a ton of notes. Dr. Harris, you should take a spot on the evening news or something, because your explanation at the beginning of this was
Spot on.
fireman simple. And man, I appreciate it. I appreciate the information more than you know. And I've been texting while this was going on, telling Chief McNeil and my guys, this is something that you should sit down as a station and pull this up and watch it. I think it's absolutely valuable.
Great message. Well, guys, thank you so much. Pete, our producer, thanks for hanging in there with us. Bobby, you're awesome. You always let us go long, especially when we've got one like this. I sent capital letters to Terry a while back. This is just incredible, guys. Thank you so much for what you do. So to our viewers, any questions whatsoever about this, get a hold of Russ or Mike, get a hold of Dr. Harris. We'll be doing some stuff. Contact Chief Robertson with Fort Worth if you got questions about how they're making it all happen. And like Dr. Harris said, take care of your people. As I close out here, we're all on social media one way or the other. This will be on YouTube later on when Pete puts it on there. Our next show will be February 17th. Like I said, normally we've got the third Wednesday of every month. Fire Engineering always has some great Hump Day hangouts here Wednesday at noon Central, and our podcast that Bobby has guys doing at night. And we never, ever, and I know Russ and Mike will love this, we never end any of our shows or podcasts without this statement, and that is, we always ask you to please keep the men and women serving in armed forces in your thoughts and prayers. Never forgetting means never forgetting. Thank you. Be safe, and God bless you.